And I'm going to go ahead and introduce just a few of our opening speakers to introduce themselves to you all and the event. This is Dr. Tooru Nemoto. He's also my boss. So I'll go ahead and let him introduce himself.
Thank you. Thank you very much for having this workshop. And this Lotus project has been funded by some substance abuse and mental health services administration. Each year we are applying for the contribution and hopefully we can get 5-year second round. And we've been doing maybe in-person workshop and webinars and consultation addressing trauma-informed care for Asian American, Asian immigrant children and family members. And for in-person workshop, this is in-person, and we have done in Sacramento and San Francisco, and one is the University of Hawaii, and Atlanta, then Washington, D.C., and Boston. And NYU, I graduated from NYU and came back after 34 years. So, it's very distracting. And most of all, I really appreciate the conferences, Hamilton-Madison and YouTube. And right now we have been exposing my daily current events, and we are now all against the and so many these things sad stories, people being arrested with the NED process and family separation. And just this one is certainly different from the previous one. We try to address current exposure to violence and family situation, and hopefully you can collaborate with other members coming here or other organizations, and that's one of our most important purpose of this function. So please enjoy.
Just really quickly, we have a couple of people this in exciting workshops today, and welcome everyone. I guess this collaboration is exciting. I think we have to do more of these things to get to know each other. One of the few takeaways is to, first of all, exchange business cards, get to know your community, and that way you can catch up with everyone else. But thank you to the speakers for coming, and to the panel and all the volunteers. And so I should say my name is Isabel Ching. I'm the executive director for Hamilton-Madison House. We run a mental health clinic in New York City for the past 40 years, Pan-Asian, Korean, Japanese, and Chinese, and Southeast Asian language. So Cynthia's here, so if you want an internship, you can go look for her there. Raise your hand, Cynthia. No, because we feel like we are a workforce. We want to build more and more people into the workforce, making sure that we are serving the community. And we've been doing this for the last, like I said, 40 years of mental health services in the East Coast in New York City. So thank you again for coming and participating. And if you did, please remember to go get a tote bag. Thank you.
My name is Lisa Suzuki, and I'm a faculty here in applied psychology in the clinical and counseling program. And I just wanted to welcome you all to Kimball Hall. It's a very cozy environment here, so we're looking forward to interacting with all of you during the course of today. I just wanted to do a shout out to my NYU alumni research team who's been working in collaboration with the Lotus Project and Hamilton-Madison House. Kyoko Toyama, who is a faculty at LaGuardia Community College, and Haruka Kokaze, who is in One Mind at Columbia University. So just wanted to do a shout out to them. We've been working on a project looking at race-based traumatic stress, and validating the race-based traumatic stress symptom scale with Asian Americans. So we're kind of towards the tail end of analyzing data for that project. It is now my great honor to introduce Dr. Sudha Arunachalam who's going to offer our official welcome from the Steinhardt School of Culture, Education, and Human Development. Dr. Arunachalam is our Vice Dean of Research and Professor of Communication Sciences and Disorders. She collaborates internationally with scholars around the world to examine how infants, toddlers, and preschoolers acquire acquire their first language, and the influence of caregiver-child interactions in learning.
It's really my great pleasure to welcome you here to NYU along with my wonderful colleague, Dr. Lisa Suzuki, for this collaborative workshop. It's just really so unusual, I think, to see such a diverse group of folks coming together on a shared topic like this. I learned from Kristen from the Lotus project that about a quarter of you are mental health clinicians working on the ground, and the other 3/4 of you come from pretty much every interested party you could imagine: clients, family members, interpreters, community advocates, government officials, teachers, professors, students. It's the most important thing we can do, right, is to bring people like you together who are tackling complex challenges in different ways, who may not get to collaborate very often, but who care deeply about strengthening our communities. I do just want to say a couple of sentences about NYU Steinhardt, because you may not know anything about what it is. We are one of the schools at NYU. We are, however, unusually diverse. We include departments from all over the performing arts, education, and health. But we do, despite these very different areas, we have this shared mission towards solving real-world problems, applied work, much of which has a social justice component, by bringing to bear kind of a holistic understanding of human development, human well-being across the lifespan. So this workshop could not be a better fit for our school, and I'm so honored that you've chosen to come here to do this work. We know, of course, as we've heard, that Asian American communities have faced significant challenges in recent years, particularly in New York City, pandemic, anti-Asian hate crimes, and currently what is going on with anti-immigration and economic challenges. And these have all combined sort of contributed to really heightened stress and trauma. So this workshop is so timely. Growing up, I found it endlessly frustrating, as may have some of you, that there's this one word Asian to describe all of these different groups. But as an adult, I see that there are really a lot of shared challenges, a lot of shared traumas, and that there's some value in lumping communities in this way. I remember a couple of years ago, a Chinese American student was afraid to commute to campus because of the rise in hate crimes. And I was able to help some of my colleagues understand this by sharing some of my family's own fears when my father was commuting to Manhattan shortly after 9/11 and experiencing substantial harassment on the subway. And these experiences obviously don't exist in isolation. There are all these social and linguistic and cultural and economic forces that shape these experiences, our mental health, our access to care, the ways that families and individuals interact with these systems. And so those conversations you're going to have today are so important. And I hope that the goal of this workshop is for you to walk away changed, right? To have new collaborations, to have new resources, not just to come and share what you're doing and then go back into your silos. That happens, and there's some value to that, but I really hope, I know that the organizers of this workshop want so much more from you than that, and so I really hope that you have that change, that you experience that change at the end of today. And so I want to thank the organizers for bringing this workshop to our campus, to Dr. Suzuki, and I want to thank all of you for your dedication to improving mental health access, equity for all of our Asian and Asian American communities. So thank you so much for being here.
Next, please allow me to introduce our keynote speaker, Dr. Francis Lee. Dr. Francis is a psychiatrist and neuroscientist, serving as chair of the Department of Psychiatry at Weill, Cornell Medicine, and psychiatrist-in-chief at New York Presbyterian Weill Cornell Medical Center. His work focuses on translating neuroscience research into meaningful advances in youth mental health.
So first of all, I'd like to thank the organizers for allowing me to speak. I think it's a really sort of out-of-the-box type of thinking to invite an academic neuroscientist to give a talk to a community workshop. What I wanted to sort of impart to you is what we are doing at New York Presbyterian and Cornell in terms of how we dealt with the youth mental health crisis in the last several years. And just in terms of how we as an academic setting try to sort of deal with not only trauma, but also the rising rates of mental illness within our population, as well as how we created a variety of resources which we hope to be able to disseminate to the community. And I think that I'd also like to spend the second half of the talk essentially going over our services and just as was mentioned, that not just to tell you what we were doing, but to hopefully form meaningful collaborations with the community in New York City to basically help everyone and basically form one. And I know traditionally academic medical centers have been very standoffish. I'm here to say we're not standoffish now. We're trying to be much more integrated with the community, and I just want to go through that. So first of all, I want to go over what my sort of view and the view of my colleagues are about why mental health is so difficult among our youth. And just to sort of show you that essentially almost all psychiatric disorders, almost 3/4 of them, emerge before the age of 25. So essentially you have, and especially with PTSD, which is later, you can imagine that also just exacerbates this. So you have an emergence of almost all the psychiatric disorders that begin during the childhood and the transition from childhood to adolescence and adolescence to young adulthood. And this is, and what we show is that essentially we have rising rates, for example, with anxiety disorders, but that essentially access to treatment is limited. And this is another sort of chart that I want to show you, is that essentially, even if you give the gold standard treatment, which is cognitive behavioral therapy plus medications, and you can get substantial decreases in symptoms, that essentially if you stop these treatments, that you actually, this is a study where they followed up 5 years later, that they essentially all the symptoms reemerge, which really suggests that we need to figure out sort of durable, sustainable ways of providing access to mental health care that will need to be done in sort of a sustained manner. So I want to go over how we try to leverage technology in very much in response to the pandemic that began in 2020, and we had rising rates of symptomology, and our ERs began to fill up. And just to give you a sense of our reach, so I'm based at 68th Street and York Avenue, which is on the Upper East Side, but we have clinics open in also another clinic, Gracie Square, on the Upper East Side, but then clinics also in Lower Manhattan, Queens, Brooklyn, and in White Plains. And also my colleague, Warren Eng, who's in the audience, could you raise your hand, Warren? He is also at Columbia, my counterpart at Columbia, and they're mainly based in Upper Manhattan, as also in Westchester. And any questions about that, please find him, and he's a wonderful colleague to discuss. So the question we have is, what happened during the pandemic is that we basically ran out of cognitive behavioral therapists. We had a long wait list. We could not really deal with this. And so we came up with the idea, and we've been thinking about this, can we actually develop a digital version that's self-guided or in some way augmenting the work that our clinicians were doing. So essentially, despite the fact that we have 250 faculty at Weill Cornell, we were overwhelmed during that period of time. And then when we looked at what was currently in the marketplace in terms of digital solutions for cognitive behavioral therapy, we actually couldn't find anything that was what we would consider sort of classical cognitive behavioral therapy. And we actually looked in the App Store, and it was unclear. And the main issues are is that there's a significant dropout rate using any of these apps. And we basically ultimately came to conclude that we needed to build our own. And this is actually something that academic medical centers are great at. We're really good at running randomized controlled trials. We really love sort of trying to get an evidence base and even trying to connect it to impacts on the brain. And so what we did is we built a cognitive behavioral therapy app called Maya, which is basically something that you can use on and either in coordination with the therapist or by yourself. Let me see if I can just. So for those of you, I assume this audience is very well versed that there are many components to cognitive behavioral therapy, but the one that's lacking in almost all apps is exposure. So basically seeing whether or not you can actually sort of challenge yourself to face your fears. So let me see if this will work, hopefully. So this is for example, there's something we call face it. So, for example, a person who has essentially a fear of eating alone, and then basically they can do their own exercises and then capture the data of how they did this by, for example, putting in their where they went to eat by themselves, and then sort of self-rate their symptoms. This app is now freely available in the Apple Store, the Android Store, and it's a tool version of what we were using. But what we have been able to do is we ran a randomized controlled trial, and this just shows you just what academic medical centers do. We're very nerdy about this. We did neuroimaging, we did EEG. I won't show you all the data. We even got behavioral economists at the Wharton School to help us put in nudges to basically see whether we could enhance the feasibility or engagement. Ultimately, it turned out that we built such a good app that all the nudges actually didn't work. Our baseline case was worked. And this is what I think is probably the main take-home point from this. This is one of the first apps that were a randomized controlled trial has been done. It was given for 6 weeks. It was actually given during the pandemic. So we actually ran this entirely remotely. And then we took the app away, and then we asked them to come back we gave them a series of surveys, GAD-7 and PHD-9, 6 weeks later. And basically what you would see is that whatever they gained in the first 6 weeks of using the app, they were able to sustain and have it for the subsequent several weeks. And we actually showed that we had significant study retention as well as adherence to the program that was above sort of the industry standard. And what we really liked about it is that now we now can break down the app and basically have it be customized. And for example, I was speaking with Isabel Ching about the fact that ultimately this is all in English language right now. It's possible to ultimately make a Chinese language, Korean language version, which we have not made this yet, but this is something we're considering. But I think that what I'm really excited about is that when we really began thinking about the youth mental health crisis, what we really came across is that ultimately we just don't need to help adolescents who use CBT. We actually need to basically go even earlier. And one of the best prevention modules is to actually engage parents. And we created a program called Empowered Parent Program with many different components, which I can unpack for you. But ultimately, one of the cornerstones of this is that we actually are created an app for parents, which is very different than an app for young adults. But it essentially will allow parents to deliver CBT skills to their kids. And this way, it takes care of two problems. You're not giving digital devices to your children. You yourself are using digital devices to impart how to have your kid become braver and other things. So I think this is something that we will hopefully roll out in the next few months. We will actually be giving it to all our parents in our pediatric clinics, so that essentially when pediatricians notice that there's parents that are having difficulty with their kids, even before they meet the diagnostic criteria for anxiety and depression, they will start disseminating this. And ultimately, what we would also like to do is basically put in front of the app a more sophisticated symptom tracker. So we've created a symptom tracker that has not only the standard sort of survey tools that all researchers use, but we also have social determinants of health and other aspects of how to basically come up with a rich data set. And what we hope to be able to do is basically create a symptom tracker or disseminate a symptom tracker with the parents as well as kids can use on a weekly to monthly basis. And what we're about 6 months away from creating is a symptom tracker that where the child basically gets to put in their own symptoms, the caregiver gets to put in the symptoms that they're observing, and then the clinician on the back end will get a dashboard where they can also sort of monitor symptoms. And this is, I think, ultimately what I believe to be the funnel that will allow us to basically allow clinicians, for example, to be able to see their patients in a much more rapid way. And I think this is sort of the next steps of how we're thinking about it. Again, there is a simplified version of this available for free in the Apple Store called WCM Rise, and we want everyone to try it and give us feedback on it. Again, all of this, by the way, has been supported by philanthropy as well as federal grants. So this is not a commercial. We actually lose lots of money. there's no profit here. So this is mainly for our research enterprise, but also to try to ultimately disseminate it. We will feel that we are successful if we can disseminate this, not just only in Weill, Cornell, and Columbia clinics, but also ultimately into the community. And so what we hope to do is ultimately gather enough data so through these different apps to basically create a database and then use predictive AI. So this is what we're doing at Cornell and Columbia. Then what we can do is basically have a rational treatment decision of whether they need low, medium, or high touch services. We essentially have, I say just like you, we have essentially a limited number of providers. We cannot serve everyone with once a week psychotherapy. This will allow us to basically see whether we can stratify people to get either an app-only intervention versus a hybrid or a group versus an individual psychotherapy. I think this is how we think we will ultimately be able to serve our communities at Weill, Cornell, but hopefully also serve our communities in your Presbyterian, the entire enterprise. And the second part of my talk, I just want to go over, again, where we are right now. We basically are in various parts of Queens, Brooklyn, Manhattan. We are the second largest provider of inpatient services in New York City. And I just want you to know that we are here for the entire communities. And I will be giving out the contact information for the various hospitals, but essentially whichever hospital you enter, we will find the right hospital bed. We also have we opened in last year the Center for Childhood and Adolescent Behavioral Health. It is essentially both based in White Plains, Manhattan, but it also has virtual components. But what we're trying to do is essentially build the largest acute care services for our region, so that we can essentially basically, if you, for example, what we knew the main gap was that after you go, if you have someone that ends up in an ER, and it's going to be extraordinarily difficult within those 24 to 48 hours to find a provider. We will provide that what we call the bridge to care, and we will be able to provide this. And again, this is for everyone. This is Medicaid, Medicare, all insurances. This is what we, and so when I can provide these slides to everyone, but these are the services we'll be providing. We also will have an intensive outpatient. We have an intensive outpatient program, which is virtual, so you don't have to actually, it can be any of the boroughs of New York. And that essentially what I want to really point out here is that we are also opening our doors for everyone to get an evaluation visit. So we will not be able to take everyone into our outpatient clinics, but we'd be more than happy to provide a high level detailed evaluation and then connect with community providers to basically then place them in the right community setting. I'll stop here to basically make sure everyone can. This is the phone number if you want to get to this, and also you can also just email us. But we really want this to be something that will serve the entirety of our enterprise in Manhattan and Queens and Brooklyn and all of the boroughs. I will end by talking about our one hospital, Gracie Square Hospital, which is on 76th Street and York Avenue. We have an Asian unit there, and I just want to sort of go over what is available there. It essentially provides culturally appropriate services in a variety of languages, and we basically have an interdisciplinary staff that provides a variety of options. And I just want to point out that we really are very committed to this. We recently renovated the unit. We have interns coming from the Madison Hamilton House working with us. We would like to have more involved, and I just want to provide here the various community outreach opportunities. And just in terms of, please connect with Nadine in particular in terms of if you would like to have involvement with our inpatient services. I will actually stop here. I'd be happy to take any questions, but I just want to thank you for your attention. And I'll be around all morning long and happy to connect there. I think hopefully this is step one of a multi-step journey where we will hopefully be able to engage more with our providers in the community. Thank you so much.